Endometriosis. Welcome to Talking with Docs. I'm Dr. Brad Winning.
And I'm Dr. Paul Zalzal.
And I'm Dr. Sandy Sharma.
If you have endometriosis, I would say you are a hero because it sounds like a visceral, painful condition. And if you are able to function somehow in your day, you are a hero. Can you please tell us about endometriosis?
Yeah, well, for starters, it's a far more common condition than we may have thought.
How common?
I'd say as upwards of 20% of women in menstrual age would have some features that could suspect it. Now, I want to preface this by all women with painful periods, which is the most common symptom, don't have it.
Right.
But if we look at patients who have a combination of painful periods, painful bowel or urinary habits during their cycle, painful intercourse, and infertility, you're going to find in that clustering of patients a significantly high proportion of patients have endometriosis.
Okay, common problem, common thing you're dealing with.
And we should probably go back and say, what is it? Well, essentially, it's a condition where, for starters, it's only going to be occurring from the onset of menstrual periods or puberty to menopause. So the natural course is endometriosis will get better once a woman achieves menopause.
Okay.
But between then, there's going to be various points in their life where it's going to affect their life. And now, initially, it's going to cause painful periods, loss of school or work function, affecting relationships because of painful sex. Later in life, as a woman trying to get a family, it may significantly influence fertility.
Okay, so pathophysiologically, which is a fancy way of saying what's really going on in the body.
Yeah. So essentially, the menstrual cells that are normally shed each month, for reasons we don't exactly know, can deposit, and there's different theories behind it. Is it coming through the tubes? Is it already microscopically in the pelvis and has a predisposition to grow? But regardless, it finds a way to implant and live outside of the menstrual lining, and it can live typically in the pelvic organs, like the fallopian tubes and ligaments around the cervix and the deep pelvis, on the pelvic structures like the bowel, the bladder. It can live on the ovaries, obviously, and it can cause large cysts on the ovaries. That sometimes is the way it's found. It can deposit on the appendix. It can deposit on, I've seen it on the diaphragm. I've seen it on the liver. We've seen it deposit as far out as the lung in, it's not a common way for that to happen, but that can.
So it can get outside of even the peritoneal cavity.
It can.
Okay.
Yeah, but typically it's a disease of the lower pelvis.
Yeah.
So along the deepest part of the pelvis, the uterus, the ligaments, the ovaries, and the cervix, and the lower part near the rectum.
Okay, and if you find this hard to believe, you're not alone. Cells that are supposed to live in the uterus are now outside of the uterus in your abdomen, in your visceral cavity, and that's why the pain associated with it can be so high.
And those cells are very specifically hormonally sensitive and driven, so they cause intense inflammation. And it is important when we have conversations with our patients, when we either clinically suspect or have confirmed with imaging endometriosis, that we remind them this is not just a surgical fix. This is a disease similar to like Crohn's disease, where you got to manage things with medication. Surgery is used for specific indications of pain that's not responding, let's say, to typical treatments, cysts that are getting larger, affecting other organs perhaps, and also at times fertility management as well. And the typical surgeries we would do would be laparoscopy to try to manage the disease, excise the disease. Sometimes we ablate the disease, we'll remove the cyst, or at times if we're trying to preserve the ovary, just remove a portion to allow the cyst bulk to reduce. And then the definitive or the treatment or the cure is to remove all of the organs, which would involve uterus, cervix, fallopian tubes, ovaries, and if there's any additional deposits. So it is a tough disease to manage. In fact, there are specialized centers that we refer our patients to when we find disease of an advanced nature, because this is a very specialized surgery. The mainstay of treatment, especially in our patients that are suitable candidates, would be the birth control pill. And not because we're using it for birth control, but we're using it for suppressing and managing the symptoms, and it does work. Probably because the progesterone counterbalances some of the estrogen in that, and that dominance allows for regression or control of symptoms. There are other medications we use complementary to that, and that would include anti-inflammatories, which you gentlemen prescribe a lot of. So any of the classes of the ibuprofen, naproxen class of medications can be used concurrently.
Any naturopathic medications?
There are
or
some
preparations that are
great
beneficial?
ways to reduce endometriosis symptoms by altering your diet.
Okay.
I think it works well. I think some of that has to do with also just reducing inflammation markers in general.
Sure.
I can't honestly say that I often refer patients to a nutritionist, or just say, go online and empower yourself with diets that seem to work and find out what works for you.
A little bit of trial and error.
It is, and also it's individualized, because some people just don't want to be restricted into other aspects of their lifestyle.
Yep.
Other classes of drugs that are used that you can use injectable progesterone called Depo-Provera, used for birth control, but also in that similar dose regimen would suppress endometriosis. For local disease or another condition that's associated with adenomyosis, we can use Mirena, which is a progesterone IUD, which also reduces pain and it releases progesterone locally. You can see there's a progesterone theme here, right?
Right.
The estrogen dominance is what we're trying to offset. And there are tablets that are designed, Dynagest being the product, or the compound, and it's a very specific, highly potent progesterone, or progestin actually, that counterbalances or counterattacks the estrogenic components in these deposits. So it makes the pain go away, the periods go away.
Okay.
These are game-changing drugs. But the final one I want to talk about is the class that induces menopause. So that's what really gets relief.
Right.
And these medications are called GnRH agonists. And essentially they're injectable medications typically where it makes you feel like you're in menopause. But whilst you're there, you're not having pain.
Right.
But you bring on it, again, we talked about the risks and the benefits. The risks of this product also involve bone loss and hot flashes, menopausal symptoms. So we do give it with something called add-back therapy, where we give a tiny, just enough dose of estrogen or a compound similar to it to offset the symptoms and the side effects that can come
Also,
with it.
assuming you can't conceive during that time.
Absolutely. So again, we look at the life cycle of the woman. Is she trying to manage her pain and periods? Is she also looking for birth control?
Yeah.
Is she trying to get pregnant? Well, if that's the case, early intervention with a fertility clinic is recommended if someone's having troubles getting pregnant with it. It is. I tell patients it's best not to waste your time with me when you're trying to get pregnant because you need to get to a fertility clinic. Let me help you get there.
Yeah. Okay.
Having babies actually helps. The pregnancy phase plus the breastfeeding phase puts the endometriosis into a quiescent phase where it's not bothering them anymore.
Wow, there you go. There's a perk for you for pregnancy. I think the only one I've ever heard of. So endometriosis, basically, whenever we say osis at the end of something, it's not good. So the endometrium is sort of spreading in other parts of your body, and the symptoms are pain with your cycle. And the treatment.
Do you have pain outside of the cycle, or is
Absolutely.
it only?
Actually, it's a good point. So I get more concerned when a patient says, I have painful periods, but I have non-menstrual pelvic pain, or I call NMPP in my short forms. But that is actually, to me, more worrisome, because that's when you're getting into neuropathic pain, where you may not even find anything on laparoscopy, but there's inflammation there in the background, and that's the hardest to treat. Right. Again, that's where I say we need to escalate our therapy to something more global, like GnRH agonist or GnRH antagonist therapy, both of which would work for that.
Okay.
That's a good point. And there's a lot of overlap of IBS type symptoms, which you may need to help with a GI specialist as well. And there is a lot of mood and depression that can come with having all this pain, and it does affect quality of life in other aspects. So using pain modulators like gabapentin or Lyrica can sometimes help with managing the pain.
We were a little horse before the cart there, but so when you are getting diagnosed, obviously you take the history, which we do, and it's an important part of this. You do the physical exam, and unless someone has a large mass, I'm assuming that's not going to be particularly useful. What is the definitive diagnostic test for confirming a diagnosis?
Well, unfortunately, the single best test is laparoscopy, which we don't want to use as our diagnostic test anymore. And we've gone away from that. I can tell you from my training days, it was a diagnostic laparoscopy. It was a commonly used procedure.
Laparoscopy is where we just put a camera inside your abdomen.
Exactly. So we now say it's a clinical diagnosis.
Okay.
If you have the right symptomatology, the physical exam, often you'll identify areas of tenderness.
Sure.
You have enough to make the diagnosis and proceed with treatment. So there is no requirement to do a laparoscopy before saying, I think you have endometriosis, here's the treatment, let's go after this.
Yep.
You will have upwards of 20 to 25% of patients where they're not getting better. You have to change the treatment, or you have to now reevaluate the need for whether laparoscopy going to provide any additional pain relief.
Any role for ultrasound, CT, MRI?
So ultrasound is the mainstay because ultrasound will, especially a good ultrasound clinic, should be able to see certain things. We refer to them as the sliding sign. You can look for nodularity, you look for ovarian cysts. There's a condition called adenomyosis, which also often lives with endometriosis, or they're partners in crime. So yes, MRI is extremely helpful, but costly and sometimes difficult to access, especially in our Canadian system. CT is not a hugely used modality, but a lot of specialists in endometriosis care do their own ultrasound in their clinic setting or evaluation setting so that they themselves can get a better sense. So when we send patients for tertiary level referrals for endometriosis, they're often getting ultrasounds done at a much higher level, which a higher sensitivity of detecting it as well.
Can I try the summary, Brad?
Oh, yeah. Now we were ready for it before.
No. You ready now?
Yeah.
Okay. So we talked about endometriosis is the symptoms, which is pain, which can be outside your cycle. Thank you. And you're going to do a physical examination, which is really going to be your diagnosis, history and physical examination. Some tests that you might do include an ultrasound or other imaging, but the diagnosis is really made on history and physical exam. We used to do laparoscopy to diagnosis. We don't do that anymore. Thank God, that's a very invasive way to diagnose something. And if you're confused about the treatment, that's okay, so am I, because it's very variable and it's very customized to where you are in your stage of life. Childbearing, trying to have kids, not trying to have kids, near the end of your menstrual cycle, your menstrual life. So that the treatment is very complicated and it is a combination of surgical intervention in addition to medical intervention. And within the medical interventions, there's different types of medical interventions. However, can you give us some good news? Is treatment ultimately successful, or are there a lot of people out there with this condition that are just, I've tried everything and I'm miserable?
Well, we know that definitively if someone's tried everything and they're miserable, you'd have to have completion surgery. Really, that's the treatment that would be final endpoint. But there are ways to manage it. We're getting more and more acceptance of using things like GnRH agonist therapy with ADVAC for prolonged periods of time. We're talking several years to keep suppression going.
Okay.
So I think there is light at the end of the tunnel, but the tunnel is long and you need to make sure that you've got a game plan and you've got a patient who's got realistic expectations.
Yeah.
Because I think that's what we have to do, is set the expectations as to you'll never be pain-free,
right,
but we can make your quality of life improve.
Better.
Well, that's a good way to summarize. We can't make you pain-free, but we can try and improve your quality of life. And at the end of the day, there's a salvage procedure that does work.
Or menopause.
Yeah.
Menopause will fix this. If we can get the patient in menopause,
right,
their problems and symptoms should naturally go away too.
Wow.
There you go. So now you know if you have endometriosis, this is a very real thing. Your symptoms and your troubles are very validated and it can affect all aspects of your life. But please talk to your healthcare provider about your diagnosis and possible treatment. And if you like this video, please like and subscribe to our channel.
And remember, you may need to try and find a specialized center that specializes in treatment of this condition because it's so complicated and variable from one person to another. You are in charge of your own health.
And thanks to Dr. Sharma for joining us again.
Thanks, gentlemen.